The magnitude of ocular surface disease and evidence-based treatment options. Interviews with prominent eye care experts on dry eye disease treatment and management. This educational activity is supported by an educational grant from Allergan, Incorporated. This activity will feature discussions with experts regarding the negative impact ocular surface disease has on the quality of life of patients living with this condition. For the full overview and goal of this program, you may pause this video and read the full text. Target audience. This activity is designed for eye care professionals, including ophthalmologists and optometrists. No prerequisites required. Learning objectives. After completing this activity, the participants will demonstrate the ability to describe the epidemiology and risk factors associated with dry eye disease, discuss the impact of dry eye disease on quality of life and the productivity of patients. The Johns Hopkins University School of Medicine takes responsibility for the content, quality, and scientific integrity of this CME activity. These are our esteemed faculty that will be participating in the educational discussion. Esen K. Akpek, MD, Wilmer Eye Institute of Johns Hopkins University School of Medicine. Peter J. McDonnell, MD, Wilmer Eye Institute, Johns Hopkins University School of Medicine. David B. Glasser, MD, Johns Hopkins University School of Medicine. And Stephen C. Pflugfelder, MD, Cullen Eye Institute, Baylor College of Medicine, Houston, Texas. Please pause to review full disclosure information. Please pause here to review full disclosure information. The Johns Hopkins University School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Johns Hopkins University School of Medicine designates this enduring material for a maximum of 0.25 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. After reviewing this online activity, participants may receive credit by completing the CME test, evaluation, and receiving a score of 70% or higher. A certificate of participation will be available online immediately following successful completion of this activity. Please pause to read full Internet CME policy and technology requirements. Confidentiality disclaimer for CME activity participant is as follows. Thank you, and now we will begin our video activity.
Hi, I'm Dr. Esen Akpek. I'm with the Wilmer Eye Institute, Johns Hopkins School of Medicine. We have just completed our CME activity, the magnitude of ocular surface disease and evidence-based treatment options. We have Dr. Peter McDonnell with us, and he presented the treatment options available for dry eye patients. We will have him summarize his talk for us.
Well, Esen, it's great to be in Chicago, great to be here at the meeting with you. I always like it when the Academy meetings in Chicago. It's definitely one of our best cities. And to see hundreds of doctors come out on a chilly, rainy night to hear a course in the evening about dry eye shows, I think, just how much desire there is for information about this very common problem amongst our colleagues who treat so many patients. Most of the doctors that were here tonight said that they saw at least 15 patients with dry eye every week. You remember that answer that they gave. So it's all ophthalmologists pretty much have to deal with this issue of the dry eye patient. What I tried to address today was to look at, talk about what the literature tells us in terms of evidence-based practice in treating dry eye. And one thing that's impressive is that there isn't so much literature on dry eye. When you think about how common that disease is compared to most other diseases, and you look at the number of papers published, it's flipped. And so there hasn't been as much attention in the literature to dry eye as a lot of other diseases are. There are two major studies, the International Task Force, Delphi's panels recommendations, and the Dry Eye Workshop have both published guidelines for treating dry eye and how to grade it according to its severity and how to introduce in a graded fashion treatments for it. And the data suggests that, like with many treatment guidelines, compliance is not 100%. Different doctors have their own different recipe for how they like to approach dry eye. But I think there's probably more agreement than disagreement in general.
Yes.
And I think that people, as more information gets out and more experience, we're driving towards more uniformity. And the other exciting thing I think that's happening now in the treatment of dry eye is there's so many clinical trials underway with different companies that are attacking the problem from different approaches, anti-inflammatory treatments, drugs or agents like hyaluronic acid that may have beneficial effects to the eye. And so I think that we ophthalmologists will hopefully be seeing a number of new approved treatments available for us to treat our patients in the coming few years.
Very good. Thank you, Peter, for participating.
It's always a pleasure to be in these meetings with you, Esen. You did a great job.
With me now, Dr. David Glasser. He presented the magnitude of problem and burden of dry eye syndrome. We will turn to him to get his opinion about this epidemiology of the dry eye and the summary of it for us.
Thank you, Esen. It's been a pleasure to experience this program. There are a number of studies that look at the magnitude and epidemiology of dry eye disease. And what's interesting is there's really quite a wide range of incidence and prevalence that's been described, ranging anywhere from 7% to 30% or more of the population, probably related to the definition of the disease, the criteria, the age of the population studied. But some of the things that have been consistent through all of these studies is that increasing age and female gender are associated with dry eye disease. There are probably at least 5 million people in the United States who have either been diagnosed with or have significant dry eye symptoms. Some studies maybe triple that number. So it's a significant disease in the United States, and it has a significant impact on quality of life for patients. There are a number of studies that have looked at quality of life, and there are a number of scales that have been used to measure the impact, and we see that for patients with dry eye, there is a significant impact not only on their visual functioning in terms of visual acuity and their visual comfort. Patients often describe burning, itching, tearing, heaviness or tiredness of the eye, but they also have an impact on other aspects of their life, their physical functioning, their emotional functioning, their ability to work. So in addition to the actual economic impact on the medical system of dry eye disease, which is in the several $billion-a year range, lost work and lost productivity at work amount to probably $50+ billion a year. So really a huge problem. Enormous problem. So a lot of patients may be underdiagnosed or undiagnosed with dry eye because a significant percentage of them never go to talk to their doctor about it. One study showed approximately 40% of patients actually sought help for treatment of dry eye. So we really are in a position to help a lot of these patients if only we can have access to them. One of the things that we discussed also was the etiology of dry eye. You know, we have a number of different causes of dry eye, and there are a number of ways of looking at it, anatomically, pathophysiologically. And one way to look at it is looking at the components of the tear film. So we have the aqueous component of the tear film, we have the lipid component, and the mucin component. And people for a long time thought of dry eye as aqueous deficiency. And over time, we've realized that a significant portion of our patients actually have a lipid deficiency or evaporative dry eye, and a small percentage have mucin deficiency. And as we've learned more about dry eye, it turns out that really calling it dry is perhaps not the best term, because there are a lot of patients whose eyes don't feel dry.
They're actually wet.
And they're wet. So, you know, they may be producing reflex tearing, they've got inflammatory modulators, especially those who have meibomian gland disease. So dysfunctional tear syndrome is probably a better term than dry eye disease. And it actually is helpful in communicating with your patients who comes in and says, you know, I use these tears and they're not helping and my eyes are dripping. What do you mean I have dry eyes? And you're already behind the 8 ball with some of these folks. If you can explain to them that it's not a quantity problem, but it's a quality problem, you really have made a big step forward in helping them understand their disease. From the physician standpoint, we discussed some of the specific etiologies associated with aqueous deficiency, lipid deficiency, and mucin deficiency, and you know how we can treat those differently. And I think you're going to discuss that in some of the later talks. And we also discussed some other factors that can impact the severity of dry eye: neurotrophic component, toxicity. Topical drops. Anybody using topical drops with preservatives in them more than 3 or 4 times a day is at risk for exacerbating their dry eye symptom, even if it's a preserved artificial tear. So I think there are quite a few patients out there who would benefit from diagnosis of dry eye disease or dysfunctional tear syndrome.
Thank you, David. This helps. Dr. Steve Pflugfelder told us about diagnostic modalities in dry eye syndrome. I just would like to turn to him and ask whether or not there is any favorite diagnostic modality that might help in these patients.
Well, Esen, thank you for the opportunity to participate in this continuing education program. There's been a real major paradigm shift in dry eye over the last decade, where doctors now consider dry to be more of a problem with tear composition than just the amount of tears alone. And in fact, many experts have now suggested that dry eye be changed to a tear dysfunction problem. There are a variety of new diagnostic tests that help to classify dry eye, to gauge the effects of dry eye on visual function, and actually to evaluate different components in the tears. Despite the availability of these new tests, most doctors still rely on the standard diagnostic tests, but I do think in the near future that a lot of them will start incorporating these new tests, and perhaps actually evaluating tear composition will be the way of the future. It's now recognized that aging changes on the surface of the eye contribute quite a bit to the development of dry eye, and one of the things that has turned up is that conjunctival chalasis, or a loosening or redundancy of the conjunctiva, will interfere with tear dynamics on the surface of the eye. It will compartmentalize tears and lead to increased levels of inflammation in the tears. And finally, there's this very interesting paradox in dry eye that's evolving, that there's often a disconnect between the signs and symptoms. Some patients with very mild dry eye, where we don't see any objective evidence of dry eye, complain bitterly of irritation. And while some of the patients that have the most severe ocular surface disease using dye staining often complain of no irritation of their eye due to degeneration of the nerve endings. This complicates the diagnosis of dry eye, but it particularly is a problem in conducting clinical trials where you have to demonstrate improvement in both signs and symptoms.
Well, I certainly see the patients that you just mentioned, the ones that complain of dry eye who don't have any findings, and the patients that have obvious dry eye who don't complain about it. So the newer diagnostic modalities may be very helpful in those cases. Thank you, Steve.
Thank you, Esen.
Thank you for participating in this activity. Please don't forget to take your test, and also for further additional CME activities, please visit our website at www.jhasio.com. Thank you.